Good afternoon, everyone. I'd like to welcome you to today's webinar, Physical Therapy in Vascular EDS, with physiotherapist Jane Simmonds and cardiologist Siddarth Prakash. My name is Sarah Jo Ritchie, and I am the volunteer coordinator at the Ehlers-Danlos Society, and I am your moderator today. This webinar is part of our ongoing series, Living with EDS and HSD. So this is how today's webinar is going to work. Webinar attendees will be muted at all times during the webinar. If we have time left at the end of the webinar, our hosts will try to get to as many of your questions as possible. So what that means is that at any point during the webinar, you are able to type any questions you may have into the question box at any time. And please make sure you're submitting them to the question box and not to chat. If you put your questions in the chat, I can't guarantee we will see your question before the end of the webinar. Please do not send your questions more than once. It will not increase your chances of having your question answered. It will only make it harder for us to sift through the questions and to make sure we are able to get to as many of your questions as possible. Jane Simmonds is a physiotherapist with more than 25 years of clinical experience working with people with Ehlers-Danlos syndromes and hypermobility spectrum disorders. She is very committed to helping to improve the lives of people living with EDS through fostering and supporting teams of clinicians, researchers, and educators. Originally from Perth, Western Australia, Jane now lives and works in London, where she combines an academic career at University College London with clinical work at the Hypermobility Unit, where she leads the physiotherapy provision and specializes in working with children and families. Jane is a member of the EDS Medical Board at the Society and the Scientific Board, and is a medical advisor to the Ehlers-Danlos Support UK, the Hypermobility Syndromes Association, and POTS UK. Moreover, she is chair of the International Physiotherapy EDS Working Group Committee, and Jane has authored more than 50 publications on EDS and hypermobility related topics, and leads national and international EDS and hypermobility CPD training events for health and exercise professionals. Dr. Prakash is an assistant professor at McGovern Medical School at the University of Texas Health Science Center at Houston. Board certified in cardiovascular disease and internal medicine, Dr. Prakash's interests center on bicuspid aortic valve, thoracic aortic aneurysm, and adult congenital heart disease in patients 17 years of age and older. His research concentrates on the genetic causes of bicuspid aortic valves and related congenital abnormalities involving the left ventricular outflow tract and aorta. Dr. Prakash's practice philosophy includes continuous assessment, participation in research, and guideline-based therapies. Patients rely on him for their long-term care and clear answers regarding their genetic conditions and prognosis due to his strong emphasis in genetic counseling, screening, and surveillance for all patients and families with congenital heart disease. Thank you both so much for being with us here today.
Thank you very much.
Thank you.
Great. Well, I think it's my turn to provide a brief cardiology-focused presentation on my perspectives about exercise in patients with vascular EDS. And I owe a lot of this to my participation with Dr. Peter Byers and Dr. Shireen Shalhoub in our vEDS collaborative, and some discussions about appropriate guideline-based medical therapy and new clinical trials and guidelines for vEDS. So some frequent questions that our patients ask us about exercise. One is for patients with existing aortic disease who are being monitored is to how can I remain active and live a productive and healthy life? We get frequently asked for people with dissections, both aortic and otherwise, what exercises can you recommend? And then after you've had some type of intervention or surgery, what activity levels may be appropriate for me? So to answer these questions, really it comes down to what is your risk? Because the underlying issue in many of these questions is what is my risk to have a dissection with exercise? And as I'll try to show, the risk is increased in patients with vascular EDS, but the risk is not proportionally distributed. We know that there are certain risk factors that we need to address, and it's important to address these before anyone engages in a regular exercise program. The main risk factor for any vascular disease that we can control clinically is hypertension. And there are a variety of ways that we need to assess this because vEDS is such a high-risk state compared to patients who do not have a vascular disease. It's very important to do thorough assessments. Also, the type of mutation that you have, if it's a loss of function or null mutation, an exon skipping mutation, or a substitution mutation, affects your baseline risk to have a dissection and the age at which that dissection occurs, whether you've had a previous surgery or intervention on your blood vessels, and of course, pregnancy, which is generally rare, but still a very high risk factor for dissections. So all of these affect your baseline risk, and before you start exercise should be assessed. So in general, how safe is exercise for patients who have aortic or vascular disease? We know that in most trials of moderate exercise in patients who have existing vascular disease have shown safety. Particularly the highest risk group that's been tested recently are patients who had aortic repair, some of whom had chronic aortic dissections, were able to complete cardiac rehabilitation safely and successfully with improved quality of life in studies in France, the United States, and Switzerland. We also have recent data in Marfan syndrome, at least, showing that in animal models with Marfan gene mutations, moderate exercise appears to slow down aortic disease. Of course, similar data on vEDS is going to be very important to show. On the other hand, we have to balance that with the idea that sudden, intense, and dynamic exercises have been, in some cases, associated with aortic dissection. This initial data came out of the Yale study of aortic dissection survivors that showed that 25% were engaged in vigorous physical activities immediately prior to dissection, and has been widely quoted as a reason to pursue restrictions on exercise in patients with established vascular disease. As I'll show you, the risk is still relatively rare and is largely confined to people with uncontrolled hypertension who were not taking any prophylactic medications at the time of the dissection. So we know that being on prophylactic medication of any type lowers your dissection risk. And in most cases, in these follow-up studies, patients who were taking those medications did quite well in controlled, supervised exercise programs. So why is blood pressure such a key component related to exercise and dissection risk? That pulse pounding that you feel when you're exercising is in fact the distension of blood vessels, the distension of which the force on the vessel wall is what directly impacts your risk to have a dissection. So therefore, the higher the pressure, the more likely it is to cause damage. In addition to that, we know that structure of the vessel wall itself predisposes you to have tears or defects in the wall. And this can relate to a pre-existing aneurysm that might have been detected by imaging, having a thin aortic wall due to loss of material that supports the structure of the aortic wall, which definitely happens in vEDS. And of course, that is related to the type of mutation and previous surgeries or interventions that you might have had on your blood vessel. The point is that we can fairly accurately assess these now and give you an estimate of your baseline risk and then provide personalized risk estimates for people to guide the types of activities they pursue. So of course, in the guidelines for thoracic aortic disease, which did not specifically include vEDS, but it considers high-risk patients with dissections, blood pressure maintenance at baseline is very important. And so before pursuing any exercise, we do try to ensure that patients achieve blood pressure targets, which in general are below a systolic blood pressure of 130 and a diastolic pressure of 80 at rest. This does not account for blood pressure or other changes during exercise, which I will go into. And in general, for people with vEDS and thoracic disease, we recommend prophylactic medications, especially for those who are hypertensive, with either an angiotensin receptor blocker or a beta blocker, or in some cases, a combination of medications if people are hypertensive. So the other point is that this should be part of a lifelong surveillance program because every child and adult with vEDS requires lifelong screening for disease, even if it's not present at the initial screening. This includes annual checkups with your primary care physician, annual blood pressure checks and medication adjustments, and more frequently if possible. And then of course, detailed imaging of your blood vessels to know your disease status, which includes imaging by computed tomography or magnetic resonance every 6 months up to a few years, depending on your disease status and the location of where your disease. This could be different for different parts of the body, such as a neck vessel that is dissected, might require more frequent monitoring. So in terms of the blood pressure, it is very important in vEDS and in other conditions to monitor your blood pressure and know the true impact of your blood pressure on your daily life and your exercise. The reason for this is that blood pressure measured in the office dramatically underestimates your risk. We know this based on studies that compared blood pressures measured in the office to those measured in 24-hour ambulatory monitors that people wear on their cuff, as a cuff on their, with an automated device. And this indicates that in up to a third of those cases, the office readings are not reliable, in that they may indicate a patient is hypertensive when he or she is not, or they may indicate that the patient is normotensive when they actually have high blood pressure at home. And I'll show you some examples of this. We know that this correlates better with long-term outcomes than a single office reading. The other thing that doing a 24-hour ambulatory blood pressure can show is daily dips and surges in your blood pressure, which themselves can be predictive of your risk. For example, how does your blood pressure change with daily activities? Does it dip normally when you go to sleep? Does it increase dramatically when you wake up? All of these things can point to an increased surge in blood pressure with exercise that may be abnormal and may mark you as a higher risk for specific types of activities. So we recommend doing a baseline 24-hour blood pressure on all of our patients, but especially those who are considering exercise, in order to optimize this before they start. This is an example of some phenotypes that we look at. When the blood pressure does not drop at night, it can mean that you're at increased risk for exercise-induced hypertension, and I'll show you an example of that later. We also know that long-term patients with any type of vascular disease are at higher risk if their nighttime blood pressure is unchanged or higher than their daytime blood pressure. Those are called dippers or non-dippers, which we can also get from this reading. So this is an example of a patient that I have who had a 24-hour ambulatory blood pressure reading. This is what they look like. Each of the dots on this scale is a single blood pressure reading. On the bottom is the time of day, which represents a 24-hour period in this patient. And the purple shaded area is the nighttime when the patient was asleep. What you can see is that the systolic and diastolic pressures are in red and blue, and they show a dip at nighttime, which is normal, but during the daytime, they're quite elevated. They're above that purple bar, which indicates the upper limit of the normal range, which is around 130 to 135 millimeters of mercury. So this patient has sustained hypertension at rest and would need to be controlled with medications before beginning an exercise program in order to optimize their risk. We call this stage 1 hypertension because it's mildly elevated, it's not severe. This is another patient who actually has largely normal blood pressures during the day, but if you follow it out to the right where that purple shaded area is, you can see that the blood pressures are rising during the nighttime hours, sometimes to dangerously high levels. And if you check this patient's blood pressure during the day, you would assume that they have normal blood pressure, there's no problem. This patient has sleep apnea, which is a very common diagnosis with vEDS and can be treated to actually reverse this pattern. So that's something that would need to be done before you'd start an exercise program in order to ensure the patient had optimal health. So this is called reverse dipping, and it's usually a sign of sleep apnea or a central problem that can be treated medically as well, but usually requires follow-up. And this is an example, a frequent example that we see of a patient that has what's called episodic hypertension. So this patient could check their blood pressures at morning and at bedtime and they would be normal. But as you can see in the middle of the day, when they're having lunch and exercising, the blood pressure surges to very high levels, close to 200 millimeters of mercury. This would not be detected unless you had done a 24-hour blood pressure monitor or an exercise blood pressure study. So this exertional hypertension could indicate surges in blood pressure related to exercise or to, say, a salty meal in the middle of the day, but it would definitely need to be investigated before this patient engaged in vigorous physical activities. So this is episodic hypertension. And then this is finally the last pattern that we see in the clinic, where we have patients that are very high blood pressure in the clinic, but as soon as they go home, they normalize. And that can be, that's called white coat hypertension. It's very common. But the treatment of this usually involves reassurance rather than any medical therapy, because that could actually make a patient fatigued by over-medicating them if you were to treat them only on the basis of their office blood pressure. So these are examples of medications we do use, as I mentioned, beta blockers and angiotensin receptor blockers. And the important thing to know about vascular risk in vEDS is that most people who had dissections while exercising were not taking what we would call adequate doses of blood pressure medication. How do we determine what an adequate dose is? We increase the dose until you develop side effects. We want the resting blood pressure to be below target, and in general, as low as you can tolerate, because we know that the higher patients in clinical trials in vEDS who were on higher doses did better. In general, in clinical trials, they try to push the dose to the maximum tolerated dose. So that should be the paradigm we use for our clinic. And in this case, we also know, and I'm sure Jane will talk about this more than I do, that the type of exercise is really associated with the risk as well, because there are quite different patterns in aerobic or dynamic exercise and isometric exercises. The difference being you're moving your body in one and you're quite still in the other, pushing against with very high pressures. In dynamic exercise, you tend to see a pattern where the pressure will rise, the blood pressure will rise and plateau, and may remain elevated for some time, but then gradually decrease after you stop. Whereas in isometric exercises, especially depending on the type, like with heavy weights, there can be dramatic fluctuations. And these can actually increase blood pressure to very high levels, up to 250 to 300 millimeters of mercury when you approach fatigue. So it's very important to emphasize that the type of exercise also has a major impact on a patient's risk. So what is the exact difference between isometric and isotonic exercises and aerobic exercises? Well, in isometric exercise, the systolic blood pressure generally increases in proportion to the percentage of your body weight that you lift. The increase is sudden and short-lived. It's very difficult to measure the exact change in blood pressure during isometric exercises because it depends on your breathing techniques. Oftentimes, these can interfere with our non-invasive methods of measuring blood pressure. There's limited opportunity to adjust the intensity of the exercise before you reach your threshold. And so therefore, it is very hard to counsel patients to do this adequately and safely unless they know how to improve their technique to minimize the impact of the isometric exercise on blood pressure. Aerobic exercise, on contrast, is more gradual and prolonged. The increase, however, is not necessarily predictable from the baseline blood pressure, as I'll show you. You can measure it. We do readily measure systolic blood pressure during treadmill exercises, which are aerobic. And you can have an opportunity to adjust the intensity of the exercise before you reach a threshold that is deemed unsafe. This is an example of a chart from that indicates the relative dynamic and static components of various activities. It's sometimes helpful to counsel patients about what might be less and more risky. And you can see in blue, I've marked the exercises that generally stay around 4 to 6 METs, which is considered to be the moderate threshold for activities. And most of them are not things that patients often ask me about. The things that patients ask me about tend to be more vigorous things like weightlifting, long distance running, basketball, soccer. All of these things are outside those limits. It's important to note that sex is in the 3 MET range officially, and so it is something that patients do ask about, but it's well within the limits of moderate exertion according to the chart. The Marfan Foundation actually did publish physical activity recommendations that largely mimic that chart. In other words, they want moderate intensity or less than 50% of your aerobic capacity, maintaining your heart rate about 100 to 110 beats per minute, depending on whether you're taking beta blockers, and generally avoiding sudden changes in your exertion or in contact sports where there would be physical trauma, as well as heavy weightlifting and so forth. So these are consistent with other activity guidelines that are not as specific for aortic disease, but they're really based on expert opinion, and they're not based on individual patient data. So what about the association of aerobic exercise with cardiovascular events? This chart shows a 20-year follow-up study of patients who exercised on a treadmill and were stratified by their peak systolic blood pressure with stage 2 exercise. This is very mild exercise. It's well below the moderate 50% threshold that I just mentioned. The idea was that even 20 years out, systolic blood pressure can predict survival and cardiovascular death. And this shows that there's a graded difference based on how high your blood pressure got. Less than 147 was the baseline. And above 160, the curves start to separate out, such that patients above 180 had a 15 to 20% increased risk of cardiovascular events or death over 20 years. So even early on, there's separation based on exertional hypertension and survival. And this is why we try so hard to characterize this in our patients before they engage in an exercise program. This is an example of a treadmill test on one of our patients. It is the standard Bruce protocol test where the speed increases every 3 minutes, and we measure blood pressure at each stage. Generally, we see a graded increase in blood pressure until the end of exercise and a slow decline. There are some patients who develop severe hypertension even when their baseline blood pressure is normal. And usually within a few minutes, we can tell who these patients are. In those cases, the blood pressure often remains sustained well after the cessation of activities. And this marks, again, a higher risk group that would need more intensive counseling and possibly improved medical therapy before beginning an exercise program. We also know that there are vascular characteristics that we can measure in the clinic that predict outcomes. This is the sphygmocore system. It measures the stiffness of your blood vessels, particularly the central part of your blood vessels in the chest. And it also predicts the likelihood that someone will experience a vascular event. The machine is a computer that calculates the blood pressure based on the stiffness properties of the blood vessel. And even if you have the same blood pressure reading, you can get two very different stiffness readings. And that gives you information beyond blood pressure to risk stratify your patients. This is called arterial waveform analysis, and we do that for everybody in the clinic. So the idea is that if you have a stiff blood vessel, this peak will be higher, and you can pick this up immediately independent of the baseline blood pressure. These are examples of real vEDS patients who were analyzed with arterial waveform analysis in our clinic. So patient 1 is a 53-year-old man who has had no dissections. He has aneurysms, but has not had a major vascular event or intervention. And in his case, as shown up here, his aortic waveform, his central waveform was normal, and he had minimal of what we call augmentation, that is the peaking of that initial surge of blood pressure in the central aorta. So this is minimal augmentation indicating normal vascular stiffness. In contrast, here's a 26-year-old woman with vEDS who had multiple previous dissections. In her case, she has not had any part of her aorta replaced, but she has had several peripheral events. And she experienced this peaking of the early systolic pressure, which is what we call augmentation. And that indicates markedly increased stiffness, particularly for her age, because blood vessels do tend to stiffen as you get older, but should not be stiff in a 26-year-old. So we think you have to treat all three components of hypertension, the exertional hypertension, the ambulatory, and the vascular stiffness, by measuring them first and then considering them in patients with vascular disease who are considering exercise. So in our clinic, we do provide exercise guidelines. Most of them are related to the official guidelines that are published by the Marfan Foundation and by the AHA and ACC. but we also do these additional kinds of risk stratification procedures, including, of course, their genetic evaluation to determine what kind of mutation you have and how that predicts your vascular risk, a waveform analysis to look at vascular stiffness, an echocardiogram to look for aortic dilation or valvular disease. And for patients who are considering vigorous exercise, we do a treadmill test to determine if there's early exertional hypertension, as well as a 24-hour ambulatory test to assess episodic hypertension and other markers of vascular risk. All of this will lead to targeted antihypertensive therapies and an exercise prescription for patients so that they can be more confident about their vascular risk and have a plan for addressing it. And I think that's the end of my slides. Thank you.
Thank you so much. We're going to jump over to Jane now, and she's going to give a more physiotherapy view.
Hang on. Sorry, I'm just getting a question list. Right. Okay, so I should be able to pick this up now. Hopefully you're now seeing my slides.
That is correct.
Yeah, so thanks very much. And it was fascinating to be listening to Siddarth. Thank you very much for that. And it really does set the scene for some of the things that I'll be talking about, which is very much a kind of practical approach from a physiotherapist perspective. And I'll be covering a little bit more broadly some of the areas as well. I suppose beyond just the vascular aspects, but the other things that that I see. So very kindly, I think we've already had an introduction, but I'm not sure where people are attending from all over the world, I expect. But as we're not traveling now with COVID, this is just to give you a bit of an insight into London. There you can see the Thames. And the university where I work was the University College London, and the NHS where I also do some work in the hypermobility unit there, or the Ehlers-Danlos unit, and at the Wellington Hospital in the other unit. And those are just a recognition of the charities which I work with. So in terms of my caseload, I see about 75% of my patients have the hypermobility spectrum disorder. About 15% have a diagnosis of hypermobile Ehlers-Danlos. About 10% have osteoporosis, because that's my other area of specialty. About 2% with classical Ehlers-Danlos, 2% with Marfan, and 1% with vascular EDS. And as you know, of course, vascular EDS is a rare condition. But over the 25 years that I've been working with my 1% of my overall total workload, I've seen a reasonable number of patients. And of course, there are people who have returned to see me as well over the years. Plus, I provide sort of assistance and advice for the therapists across the UK, particularly the UK, but probably across the globe, as we start to develop our knowledge and understanding in this area. And there's often a lot of concerns from therapists wanting to give the right advice. So the sorts of things that people come with are listed here on this screen. Subluxations will be there, because actually we do see subluxations and hypermobility in the peripheral joints. We see some dislocations, people sometimes coming with pain, they've got problems with their hands, they're deconditioned, sometimes they're low mood, their balance is problematic. A big part of what their experience is fatigue, so tiredness, some of them with the sleep apnea. So these are the sorts of things that people come with. And of course, when they actually come to see me, they're wanting often a treatment of pain, fatigue, joint instability, and advice on exercise and sports participation. As Siddarth has said, these are often the big questions, but around that, we're treating the other things as a physiotherapist that other people experience. And you know, we know from the research evidence, the description of patients with vEDS, that actually in red, these are the sort of common things that we understand and know. But as I said, I also see people with pain, with the fatigue, the deconditioning, a feeling of reduced strength, sometimes feeling quite angry because they've not really been able to get the advice that they've needed, anxiety, and associated with that is low mood. So I really try and look very holistically at them and work with them using our evidence-based approach. And the thing about this area, very kindly and helpfully, Siddarth has given you some of the background research, but as we know, there's quite limited research so far in terms of vEDS and exercise, and even in general management, that's a growing area. So we have to draw on research evidence from other related areas. We look at our clinical assessment and, of course, working with the patient's values and beliefs to try and come up with a personalized approach. The assessment, therefore, is very much a biopsychosocial approach. And in there you can see that we'll actually be sort of really listening hard, exploring in the background the medications, talking about monitoring, understanding those things. And then I'm looking for the things that are contributing to the symptoms that they're experiencing. And I'll do that within that kind of framework there on the right-hand side, thinking about what the biological aspects are. And you can see there I've just highlighted blood pressure because that's something that I'm very mindful of in terms of the biologics, but also I'm thinking about other things in there that might be impacting and how the psychological areas may be there, but also the social parts, because that's all going to impact on how we actually deliver our treatment. And then, of course, it's really important that we start to explore the expectations. And Siddarth again highlighted that that a key thing here is actually the expectations in terms of what people can be doing in terms of exercise, I think really is something that's very important. And using those MET charts can be very helpful, but I do go through a process of advising on exercises that we know are helpful for reducing blood pressure, but also there are exercises where we don't see, we try to reduce the sort of limits of blood pressure as well. And we do that, our whole assessment we use the International Classification of Functioning, where we really think about, okay, how is this person operating in terms of their body structure and functions? What impairments do they have? How is that impacting on their daily life, on their functions, their activities? How's that impacting on their participation at work, their ability to participate in sports and recreations and social life, and other things that might be impacting. And ultimately, once someone has a diagnosis of vEDS, and actually they've had some of the testing that Siddarth was talking about, it then actually, a lot of the process then comes to actually someone being able to accept that condition, to think about what needs to change or how they're going to manage those, how the family, how themselves are going to manage those symptoms, and really start to take control of their lives so that they can have a better quality of life. So I guess the clinical reasoning and the approach that we have to managing vEDS is that we treat the treatable and managing everything else. So in terms of the things that we talked about, the vascular fragility, well, Siddarth again has talked about that in his presentation, that monitoring and minimizing risk becomes very important, particularly around managing blood pressure. Thinking about if you've got problems with the skin, it's again about educating and teaching about skin protection. And we also educate other health professionals about what that might mean in terms of surgeries. In terms of the peripheral joint hypermobility that we more often see here, it tends to be in the small joints of the hands and in the feet. Again, we'll talk about education on joint protection, how to manage a dislocation or a subluxation, teach about splinting, and I'll talk a little bit more about that in a moment. Fatigue, which is often a big factor. Again, giving people advice on sleep, routines with sleep, good sleep hygiene, having a darkened room, avoiding too much screen time just before bed. Those who have sleep apnea, we're often using CPAP masks. So this is a way of managing the sleep apnea and bringing and helping to reduce blood pressure issues as well, and also reducing fatigue. But we might look at other things like vitamin D, iron and pacing techniques as well. Spontaneous pneumothorax is obviously something that we're mindful of. So again, this is going to be generally within the realms of the physicians. But again, patients need to be aware of that. The deconditioning is obviously the key thing for physiotherapists, and it's actually where people have reduced strength and endurance. We're then thinking about what sorts of exercise and sports advice can be given. I'll come to that in detail in a moment. But the other key thing is actually how to manage mental health, because it is stressful living with a long-term condition. And so at times psychology or health psychology can be helpful, mindfulness, hypnosis, and also some of the exercises that we do advise on and recommend can also be helpful. And I've just put an example there of Tai Chi, and I'll go into a bit more detail about why I think that could be helpful. So in terms of the education and advice we might give around the splinting. So this is for the joint aspects. Actually, the use of silver splints or ring splints can be incredibly helpful. And they don't have to be made of silver. They can be this plastic sort. And you can see here how much stability patients can get from the use of ring splints. Now, this research was done in people with hypermobility spectrum disorder and hypermobile and classical EDS. It wasn't the vascular group, but the principles apply. And the outcome of this research is actually, in using these sprints, actually people had a lot more strength, were able to do a lot, they had a lot more dexterity, and their functional tests improved as well. Teaching how to manage a dislocation or subluxation. Again, this is really important. If it's in the fingers, the wrists, or in the feet, again, we help people to teach them about positioning the joint, breathing, relaxing. You sometimes need some distraction. It might be about waiting then. And usually people get used to whatever their usual thing is once they've had some distraction. Ice might be helpful. Heat might be helpful as well. The trouble is, if you panic, if you're stressed about it, it actually often makes the dislocation or subluxation worse because the muscles pull around it. And then it's really about perhaps supporting for a few days and then trying to teach people how to avoid it in the first place. So thanks very much to Helen Cohen for the use of that slide. Other things we might advise on would be around footwear and podiatry. Again, if it's ankle and foot problems, avoiding this kind of footwear, which puts a lot of stress, particularly on the metatarsals, but also giving advice on training footwear, which can be very supportive and helpful in terms of pain management. The main things to think about are having a really good heel cup, arch support, and some padding underneath the metatarsal heads. And then, of course, we'll also be giving a range of exercises, including balance exercises, to prevent ankle sprains, foot problems, and other things. So those sorts of exercises, very, very important. Other areas that we'll help in terms of managing pain or problems that people might come with, we might use our manual therapies. Now, I guess the caution here, any therapists in the room or listening in the webinar, what's key here is we obviously need to be very, very mindful of the tissues. So it is about being very gentle here, but there's nothing to prevent, if you're watching very carefully, why we can't use some of these techniques for patients who are struggling with their musculoskeletal problems as well, which they do have. Managing fatigue and pain management, again, teaching people about the sorts of activities that might be, I suppose, about conserving their energy, managing their energy by becoming much more aware about their habits, but more mindful about what they're doing and starting to prioritize so that they're not doing all the red level activities on the right hand side there, so all together, so we don't get that build up and that, using too much energy up so that we get a booming and busting. So very important that we're teaching people to learn to pace themselves, to learn which activities are appropriate so they can conserve energy and not to boom and bust. In terms of the exercises, number one, and I think we heard Siddarth talk about that there, is that we teach breathing exercises. So this is being able to teach people to breathe in sitting, in standing, and also while they're exercising. And there are some exercise forms that really concentrate on breathing rather than holding the breath. So Pilates is one of those. The Tai Chi is also another one. We know this population can be very weak, and so we really think about working at a very low baseline, avoiding isometric exercises. So the isotonic exercise is very, very important. So moving through, because what we don't want is what we call a Valsalva maneuver, where we're holding the breath and the blood pressure's rising. Whoops. Going to get sound there. So these are just some exercises here that I might be giving to strengthen up the calf muscles. But often we'll be starting in gravity eliminated positions, and then gradually teaching people how to move, how to control their joints, considering our whole person, and using our hands often to guide people, to teach people, particularly if their proprioception is also affected. We'll be thinking about customizing it based on what the person's goals are, and obviously making that as relevant to them as possible. The key thing, I think, in the prescription of exercise, or any of the patients who are listening tonight, is that you'll need to find, once you've got your blood pressure into a stable situation, is finding something that you enjoy. And some of the exercises that certainly my patient group find helpful and I feel are much lower risk are swimming, if they feel that if that's something that they could enjoy. That could be a very helpful form of exercise, and of course low contact, but very good for developing strength and control, but also developing your cardiovascular fitness. Use of the bike is part of what we do in the cardiac rehab classes as well. And again, being in a recumbent position puts less stress on the cardiovascular system. So actually, people can manage to exercise for longer often on the exercise bikes. And of course, walking is another one that people find that they enjoy. Other things to think about, we would start generally with our baselines. We use something called the Borg scale, which is the rate of perceived exertion, which tells us quite a lot generally, even if, because if people are on beta blockers and things like that, it's very hard to monitor heart rate. And it's not always possible to be monitoring blood pressure in every exercise opportunity. So we use the Borg scale to help us. And we're scaling here. We'll think about having a rate of perceived exertion, often starting at around about 4. And generally we say to people that we want them to work between 4 and 6 out of 10. And that then we know, because actually get the feedback, that they're actually exercising in a relatively safe zone. And of course, people are also monitoring their blood pressure at home as well. We teach people to be able to do that. Other things that I think are very, very helpful, this is an area that I'm very keen to work on in terms of research, is we are doing some research with Pilates at the moment for the hypermobile group. But the other group, and something that I teach myself now, is Tai Chi. And there's actually a growing evidence base for Tai Chi. It was used initially in falls management, and very good for the prevention of falls. So I think it's very helpful for our hypermobile and EDS populations. But things that actually they've been able to monitor that we do in Tai Chi is to help people with their breathing. It does improve balance, it can improve strength, and it can be a challenge for people and an achievement to learn something new and to exercise in groups. And there are also other groups which actually do Tai Chi in the water, that's I Chi. But I think there's definitely this area of using Tai Chi, which I think could be very helpful and certainly very enjoyable for a lot of people. So at that point, we can take some questions. I'll stop sharing and perhaps we've got a few moments to be able to do that.
That we do. Thank you so much for all of your hard work, both of you, on this webinar and in your practices every day. movement and exercise is a very important thing for our community, especially now while we're battling deconditioning and everything during these tough times, not being able to get in to see our providers. So I'm glad you were both able to get out here and discuss some of these safe methods of exercise and what to kind of look out for our vascular EDS community. We do have a couple questions in, and we're going to squeeze them in now. If anybody else has questions, you still have some time to submit them to the question box, and we will do our best to get to them. So our first question is, how do you strengthen the abdominal muscles to keep the core and back stabilized and conditioned while protecting the vascular system?
Okay, do you want me to start on that, Siddarth?
Sure.
Okay, so it's a really good question, because I think people, when they think of abdominal muscles, they immediately think of doing sit-ups. It's usually the first thought. And the trouble with doing a sit-up is that actually the minute you start to lift up, you start to move into a Valsalva and start to often, hold your breath there. So that's not the first one. That certainly wouldn't be the exercise to start on. I think what you want to be thinking more about doing is something along the lines of what the Pilates instructors teach, which is actually lifting the legs up. So you're lying on your back, you can brace, if you like, slightly flatten your back and lift your legs up, yeah? And actually in doing that, you'll start to, you will use your deep abdominal muscles as well. So we tend to work from the legs to start with. You can also then bring the arms in, and actually you will be getting contractions of your abdominal muscles without actually having to do that big heave into a sit-up position. So that would be my first start. I hope that partly answers what you're asking. You could sit on a gym ball. That's another one. I think the key thing is to keep the breathing going.
Anything else to add in?
I'll add that we did test blood pressure in patients who are doing both different types of abdominal activities, and we ended up using the method Jane mentioned. They lie on the floor and elevate 6 inches in our test, and that produces a modest rise in blood pressure, but nowhere near in full engagement with the Valsalva, which often dramatically increases pressures. We're seeing up to 100 millimeters of mercury. So we don't recommend any Valsalva type maneuvers or recruiting muscles below the diaphragm in isometric or isotonic maneuvers, because it does seem to be quite costly in terms of hypertensive response.
Alrighty, thank you so much. Our next question is, what activities do you recommend for those of us with vEDS limited in their ability to walk and exercise that way due to previous surgeries? And in parentheses, it says limited blood flow to extremities due to occluded bypass.
Do you want to start with that?
Sure. So for in general, for our patients who have limited blood flow to the extremities, we do recommend daily walking if possible, because that is definitely as effective as any medication to improve blood flow to the extremities, particularly for those patients who have claudication, which means your legs ache when you walk more than a few feet, and that can be improved over time. However, it is difficult for some patients with foot or ankle injuries to do that. And in that case, I think I would probably refer them to someone like Jane. So
yeah, and I think what we would do is probably see whether you could operate on a bicycle, on a stationary bike, to see whether you'd be able to manage that. So that would be my first choice. Yeah, so that'd definitely be my first choice, is to go to a bike, non-weight bearing. You can get a recumbent bike as well, so that could be quite helpful. I hope that answers that.
Alrighty, thank you so much. In terms of physiotherapy, would you use the treatment and assessment approach spoken about with the majority of EDS patients?
I'm not quite sure what was meant by that. I do use obviously a personalized approach to the physiotherapy assessment. So it's always about listening, gathering the information, using a biopsychosocial approach. But if I know somebody has a diagnosis of vEDS, then I'll know that there are specific things that we need to assess. So in particular, I will be particularly wanting to know more in the subjective history around their medications. I will be measuring and monitoring blood pressure, as those are the two key things. But actually, it's always about asking what the problems are and trying to solve the problems. So that is a problem-based approach to assessment.
Alrighty, thank you so much. Our next question is, how do you approach repeated inflammatory episodes and ankle ligaments after physio plans and exercise programs in a patient with EDS? How do you approach such cases where exercises improve initially, but then pain drives them back to square one?
Yeah. So this is a common problem in the EDS population, this kind of recurrent episodes of flares. And so what we have found, what I've found over the years is actually to teach people how to manage the flare up, firstly. So often with the use of ice, with the use of some kind of splinting or support or tape can often be helpful. You just need to be careful in the vEDS population if the skin is fragile, but actually some kind of simple splinting. And then I think it's important about why are they having these recurrent episodes? Is it that they haven't got the stability? So it's to try and get to the source of it, which is why I was showing you why it was so important in the rehab. Any physios who are attending or listening to this to this webinar, it's actually really important that we help people with the stability. And that's why I'm working towards this idea, particularly in terms of an enjoyable form of exercise, is to think about things like Tai Chi, because I think they've got a lot to offer for stability, strength, and breathing, all of which I think are helpful for this population.
Thank you so much. Is there a certain stretching program that is safe for people with vascular EDS?
Do you have anything on that? Do you cover stretching, Siddarth?
No, we generally don't talk about stretching in our practice, but I definitely have questions from patients who are concerned about their chronic pain and how they can improve it by stretching. I usually don't address those directly.
Yeah, so I think the thing is that often people in pain do get quite irritable muscles and they get spasms in their muscles. And so what I was showing you is in terms of some of the therapies is sometimes some gentle massage or some heat can be quite helpful. Controlled stretching is something that we talk about. So this is not like stretching out, stretching in an uncontrolled way where actually you're often stretch the loose bit and you don't actually stretch the bit that you need to. I think this is something I probably need to demonstrate, but I'm not sure I can do it very well from here. But there are approaches to stretching. If I describe this to you, perhaps you can imagine it. If you're feeling that you've got tension in the back of your legs, in your quadricep muscles, in your hamstring muscles, for example, that if you lay on your back and you held your thigh with your knee bent, and then you gradually straightened up your knee, you would be doing that stretch in a very controlled way. All right, you would be in charge of it, if you like. What you don't want is to just stand and just stretch out and not have control. So I think to learn to stretch in a controlled way is very important. The other thing I've learned over the years, and I've learned this from my work in sport, is actually sometimes people feel as though they want to stretch, but what they need to do is move. And again, this is where I come back to the idea, because what's happening is we're getting a bit of ischemia in the muscles, and actually we're better to move, and hypermobile people generally do better with movement. And again, I'm coming back to those exercises like Tai Chi, which are very rhythmical, that can actually help to relieve tension in muscles. So I hope that answers somewhat that question.
All right, thank you so much. Are there any recommendations of the type of cardiologist or cardiac specialist to manage vascular EDS cardiac issues?
Yes, so it's currently recommended that you seek care with, if possible, with professionals who have experience with vEDS issues, and also some access to or interest in genetic disease. So cardiovascular genetic specialist, practice that has a geneticist incorporated in the practice, like in our clinic when we see our patients with genetic counselors, so that we can really integrate the genetic diagnosis into what we do. And it is very important, as I mentioned, in terms of prognosis and the kinds of studies and follow-up that we recommend. So it's really the basis and the starting point for a lot of our evaluations, but it should also include a systematic approach in every patient, because all vEDS patients are unique. And especially when it comes to exercise, those responses are not predictable from the kinds of routine tests that we often get in clinic. So it is important to have someone with a special interest in vEDS, if possible, at a vEDS clinic, or as I mentioned, in our case, an adult cardiovascular genetics clinic.
All righty, thank you so much. We've got one more question. I think we could squeeze it in. Can you speak to what to expect after surgery in terms of healing, recovery, scar tissue, time in healing compared to non-EDSers?
Right, so that's very interesting to us because we see a lot of variability in vEDS, and it's not necessarily according to genotype. It's true that some vEDS patients do have delayed healing. This has been, you can find it on the message boards and in published reports. It's also true that many vEDS patients have normal healing. And we're not quite sure what distinguishes the two. We can't find a genetic basis. There could be modifier genes, which is what we think right now. But we also noted in some of the collagen 3A1 mouse models, they also have delayed healing. In that case, it was traced to inflammation, abnormal inflammation, affecting the formation of blood clots and wound healing. So it could be, there is certainly a cellular basis for it in vEDS, but not everybody demonstrates that. And so what we tried to, I think in my practice, what has been the most predictive is to ask patients if they had delayed scar formation or any sort of external delayed wound healing. That seems to be the most predictive. If there's clear evidence of that, then we actually work with our cardiovascular surgeons and perfusionists to design a special vEDS protocol that includes increased monitoring for coagulation cascade during surgery and the preparation for transfusions as needed. So it really is individualized, and it's not necessarily predictable.
All righty, thank you so much. And we got one last question in under the wire. It should be a very simple, quick answer. Who do you see to get vascular stiffness measured?
Right, so in order to measure vascular stiffness, there are two main techniques. You can use MRI scans, the kind of MRIs that you would get to measure your aorta or other blood vessels, can also be used to measure vascular stiffness, but only in some centers. And then the cheaper alternative is the one we use, which is a SphygmoCor device. And that is unfortunately not widely available. We're arguing that it should be, especially for anyone who does aortic or vascular disease, because it does give you independent information. And that can be done on a routine clinic visit in any office that has one. It's easy enough to ask if they have one. And most vascular services in hospitals have one, but very few clinics have one.
All right, thank you so much. But that's all the time we have for our webinar today. You both have provided a lot of really important information and some examples that can really positively affect the health and the well-being of our vascular EDS community. If you would like any more information about anything that was presented today, please check out our website for more resources and information. Feel free to give our helpline a call or email, and definitely consider signing up for our newsletter if you haven't already. It's a fantastic source for the most up-to-date information and upcoming events. Our next webinar will be on June 10th at 3 p.m. Eastern Time. We have Andrew Cantor and Beth Davis from Cantor and Cantor Law Firm, joining us to talk about and guide us through the disability claims and appeals process. You can look out for that sign up very soon. Technology permitting, this webinar should be available on our YouTube channel within the next week or so, but don't quote me on that. It depends on technology and time to get it edited, but we'll get it up. If you found this webinar helpful in any way, please consider hitting that like button once it's available on YouTube, and consider subscribing to our channel so you can be alerted to when we're uploading our videos. Once again, thank you both so much, and I hope that you and everyone that joined us today has a safe and healthy rest of their week. Thank you so much.